Welcome back to Diabetic with Files. I'm Dr. G. So, every diabetic ulcer is answering or asking a simple question. Do I have enough oxygen to survive? And we're pretty much asking that every day when we're in our new environment, right? Do I have enough oxygen? But here's the twist. The body doesn't actually measure oxygen the way you think it actually does. Instead, it relies on this tiny protein, what we're going to talk about, that acts like a thermostat for oxygen. And the protein is called hypoxia inducible factor 1 alpha, HIF 1 alpha, and it's pretty fundamental in medicine. So before HI alpha, which is hypoxia inducible factor 1 alpha, until the late 20th century, scientists understood that wounds needed oxygen, which wounds doesn't, right? All wounds need it. Tumors behave differently in low oxygen, and people living at altitude, different altitudes, right? Especially at high altitude, adapted over time. But no one knew how the cells sensed the oxygen. And the missing piece of this was that there's an oxygen sensing machinery that's inside your every cell, pretty much every cell in your body. So the Nobel Prize discovery in 2019, so this is quite recent, right? That they were awarded this Nobel Prize. The breakthrough came from these three researchers, Greg Semeza, Sir Peter Ratcliffe, and William Cataline Jr. Forgive me if I pronounce the names wrong, but they were awarded the 2019 Nobel Prize in Physiology or Medicine for discovering how cells detect and adapt to oxygen availability, and this work influenced oncology, nephrology, cardiology, critical care, as well as wound healing. So, hypoxia inducible factor 1 alpha. Imagine every cell has an oxygen detector, a survival manager, and an emergency response coordinator. Okay. And the coordinator is the HIF1 alpha. Okay. The hypoxia inducible factor 1 alpha. And it's when oxygen is plentiful, right? It is broken down quite rapidly, HIF1 alpha. So we're just going to use that acronym just to shorten it down. And then when oxygen fails, right, or is scarce, it stabilizes, enters the nucleus, pairs with HIF1 beta. So AIF1 alpha, right? The inducible, it pairs with HIF1 beta, and that actually activates a bunch of genes that help the cell to adapt to the low oxygen levels, right? So, in our normal wound healing response, immediate injury, we know that oxygen levels fall during the immediate injury. This is a temporary hypoxia that actually is a signal. And what happens is the hypoxia inducible factor 1 alpha turns on genes that are involved in angiogenesis via VEGF, red blood cell production, glucose transport, glycolysis, nitric oxide signaling, cell migration, and survival under low oxygen. So, in a healthy person, this coordination that this protein does, right, response helps launch the healing process. Now, in diabetes actually breaks down this oxygen center. Okay, so here's the paradox: a diabetic foot is quite hypoxic in a sense because of a lot of the microvascular disease, PAD, a lot of things. The whole cascade is impaired when it comes to diabetes. You have to understand that. And so hypoxia inducible factor 1 alpha should be strongly activated, correct? Because they sense that there is low oxygen levels. But instead, diabetes often impairs the hypoxia inducible factor 1 alpha signaling. So the high glucose, the oxidative stress, the advanced glycation end products, the chronic inflammation, the mitochondrial dysfunction can reduce hypoxia inducible factor 1 alpha stability and effectiveness. Okay? That's why I keep on telling people it is such a bigger, more complex problem than just the foot, right? And this could result in the wound behaving as though it doesn't recognize or doesn't respond well enough to the oxygen deficiency and to increase, right, the production of it or the signaling of it so that it can pair with the beta. Now, the downstream consequences. So when hypoxia inducible factor 1 alpha signaling is inadequate, what happens? Blood vessels, there's less VEGF, so there's fewer new blood capillaries. There's also fewer fibroblasts, so because and that causes what? Reduced collagen production, slower extracellular matrix formation. Next will be delayed reepithelialization, slower migration of the keratinocytes. Now, we already know also the immune cells, they're going to be less effective when it comes to bacterial killing and have prolonged inflammation. Diabetes kind of states that the patient is in this low chronic inflammatory state. And then our stem cells and progenitor cells, there's reduced recruitment of these cells because of actual lack of this protein being available to activate. So hypoxia inducible factor 1 alpha is actually quite challenging because it is an unstable protein that is rapidly degraded when oxygen is present. So, researchers use several lab techniques, right? Depending on whether they want to measure the protein itself, its activity, or the gene it regulates. So, how do they measure it? They use immunohistology. That's the most immunohistochemistry, forgive me. That's the most common in tissue studies. So, that is one of the most common methods that they use when they're trying to study this in diabetic foot research. So, a small tissue biopsy is taken from the wound edge and stained with antibodies that specifically bind to the hypoxia inducible factor 1 alpha. And then, under the microscope, researchers are able to determine whether the hypoxia inducible factor 1 alpha is present, which cells are expressing it, whether it's the keratinocytes, the fibroblasts, the endothelial cells, the inflammatory cells, and whether it has moved into the nucleus where it functions as a transcriptor factor. And advantages of that would show with this immunohistochemistry will show where it actually is located in the tissue and correlates with the wound histology. But, like I said, it requires a biopsy. Another way they measure is through a Western blot. This technique measures the amount of hypoxia inducible factor 1 alpha protein in a tissue sample. So the tissue is broken apart, the proteins are separated by size, and the antibodies detect the hypoxia inducible factor 1 alpha. And researchers can quantify whether the levels are higher or lower compared to the controls. Next is enzyme-linked immunosorbent assay, ELSA. And this uses antibodies to measure the hypoxia-inducible factor 1 alpha concentrations in biological samples such as tissue extracts, cell cultures, and occasionally blood or even wound fluid in some research settings, which is amazing. And then they also use polymerase chain reaction PCR, and it actually does not measure the hypoxia inducible factor 1 alpha protein. Instead, it actually measures the mRNA of that protein, the genetic instructions for making that protein. So that's what the PCR is actually testing. And researchers would extract the RNA from the wound tissue and use quantitative PCR to determine how much of the hypoxia inducible factor 1 alpha gene expression is occurring. Okay. But the key point is the higher the mRNA, right, does not mean high hypoxia inducible factor 1 alpha protein production, right? Because the protein might still be getting rapidly degraded. And they also have immunofluorescent microscopy. I'm right now saying that wrong. Microscopy, forgive me. But researchers can visualize that protein within individual cells and determine whether it entered the nucleus, indicating activation. So key factor is that if it's in the nucleus, they're saying that it's activating and transcribing, right? So why does this matter to our amazing field of limb salvage? So many clinicians, we focus on debridement, dressing, antibiotics, and offloading, and these are the essentials. But hypoxia inducible 1 hypoxia inducible factor 1 alpha, because it really is a mouthful, helps explain why two wounds may look incredibly similar and can heal very differently. One patient's molecular repair program is actually functioning well, and the other one cannot be functioning well. So the key distinction is ischemia is reduced blood flow. Hypoxia is reduced oxygen at the tissue level. So you can have hypoxia without complete ischemia. So you understanding the difference between the two is very critical in a wound assessment. Like I said, I'm going to repeat it again. Ischemia is reduced blood flow. Hypoxia is reduced oxygen at the tissue level. So there are some therapies that may influence the hypoxia-inducible factor pathways. So, revascularization restores oxygen delivery. We know that hyperbaric oxygen therapy increases dissolved oxygen and may influence the hypoxia responsive pathways in selected patients. Good glycemic control reduces factors that can impair the cellular signaling. And then ongoing research is investigating drugs and biomaterials that can target hypoxia inducible factor signaling directly. But these approaches are largely experimental when it comes to diabetic foot ulcers. So, what does the future hold for this type of therapy? So, the future of hypoxia inducible factor 1 alpha, right, or HIF targeted therapy in diabetic foot ulcers, like we said in decades, diabetic foot ulcers, we focus on debridement, infection control, offloading, revascularization. That's why we say vascular 3 times, love you vascular, and advanced wound healing and skin substitutes, right? And these treatments are essential, but they don't completely correct the underlying biological problem. And in diabetes, the wound itself can sometimes get stuck in this dysfunctional healing state. And I think we all know that, because that's why diabetic foot ulcers are very hard and very complicated to heal. You can't just slap on anything on it, right? You have to target it as a whole. So, like I said, why target HIF, right? Because it's the body's emergency response coordinator. And when oxygen fails, HIF helps tell the body, build some new blood vessels, bring some oxygen, recruit the stem cells, reduce cell death, grow healthy tissue, close the wound. And unfortunately, diabetes interferes with this whole system. So instead of activating the healing mechanism and pathway that's needed for wound closure, diabetic wounds often become trapped in the prolonged inflammatory state. Remember, that's the state that most diabetic foot ulcers are stuck in, right? And poor tissue repair. So the future of diabetic wound care could help with figuring out the switch to turn this back on and enhance the activity. So they have something they've been researching. So one of the research hot areas are hypoxia inducible factor stabilizers. Okay. So normally, like we said, oxygen causes HIF proteins to be rapidly destroyed. And the enzyme prolyl hydroxylase domain, so it's literally called PhD, enzymes ties the HIF for degradation to be degraded. And as a result, HIF activity remains low under normal oxygen conditions. But HIF stabilizers will are stabilizer actually are inhibiting that PhD protein, and that allows the HIF proteins to survive longer. And instead of disappearing, they can continue activating hundreds of the healing genes that were needed. So benefits that researchers hope to achieve to include is increased angiogenesis, more collagen production, better fibroblast function, enhanced epithelial migration, and faster granulation tissue formation. So essentially, they want to trick the cells into behaving as though they have low oxygen conditions, even if or when oxygen levels improve, because they want to increase that production, right? Now, current clinical use. So there are several HIF stabilizers that are already approved in some countries for treating things like anemia associated with chronic kidney disease, because they stimulate the body's natural production of erythropoietin, and that involves with red blood production. But researchers are also investigating whether these same drugs or even topical formulations, forgive me, based on the same concept with these could help improve diabetic foot ulcers. However, there's not a current like standard of care therapy for this, okay? These are in research a stage of it, okay? Now, gene therapy, everybody's been talking about gene therapy. So, gene therapy attempts to permanently or temporarily change which proteins wound cells produce in our field of wound care when it comes to gene therapy. So, imagine delivering genetic instructions directly into the ulcer. Instead of applying the medication directly, the cells receive new instructions. That's how gene therapy works. It's amazing. Researchers have explored delivering genes like HIF, hypoxia inducible factor 1 alpha, VEGF, PDGF, nitric oxide synthesis, angiopotens. So these genes encourage cells to make the new blood vessels, improve oxygen delivery, accelerates tissue repair, and recruit immune cells appropriately. Now, remember we talked a little bit about RNA? Are actually researching RNA-based therapies as well because rather than changing the DNA, RNA therapies temporarily adjust which proteins cells make. So DNA is the cookbook, RNA is the recipe copied from the cookbook for today's meal, okay? And researchers can modify RNA to encourage or suppress the production of specific healing proteins. So, like mRNA, which provides temporary instructions for the cells to produce beneficial proteins that help with wound healing, or the small interfering RNA, or the microRNAs. We'll get into that in another episode. And then stem cell therapy. Stem cells have attracted enormous interest because they influence healing in several ways. Potential sources are like our bone marrow, our adipose tissue, fat-derived stem cells, umbilical cord tissue, placental tissue, and we already know that stem cells they may help release growth factors, recruiting other cells to repair, promoting angiogenesis, modulating inflammation, supporting collagen production, and encouraging regeneration rather than scar formation. And then engineer scaffolds, okay? Cells also need a physical framework, and engineer scaffolds can act as an artificial extracellular matrix, okay? So they can provide structural support, protection, moisture balance, guidance for cell migration, and a platform for blood vessel growth. And modern scaffolds may come in from like collagen, fibrogen, hydrolonic acids, silk, things like that. Now, oxygen releasing biomaterials. It might seem paradoxical because remember, we just discussed or we learned today that hypoxia inducible factor responds to low oxygen. So, why release oxygen? And the answer lies in balance. Diabetic foot ulcers often experience severe, prolonged oxygen deprivation, which limits the healing and immune function. So, researchers are developing biomaterials that can release oxygen gradually, helping to support fibroblasts, improve collagen synthesis, enhance immune cells functions, reduce bacterial growth, and actually stimulate angiogenesis. And examples of these are going to be like oxygen generating hydrogels, which would be super cool or amazing, calcium peroxide based dressings, magnesium peroxide systems, oxygen loaded nanoparticles, and perfluorocarbon based oxygen carriers. So the future of this type of therapies is very multifaceted. It's quite very interesting. So the clinical pearls from this episode is that, not every ulcer mounts and not every diabetic foot ulcer, right? Because a lot of diabetic foot ulcers do experience hypoxia in some shape or form, but not every diabetic foot ulcer mounts as an effective response to hypoxia inducible factor 1 alpha, okay? And you have to also remember a lot of our patients have neuropathic ulcers, and how do neuropathic ulcers happen? Because of pressure. How do pressure ulcers form? Because of the lack of oxygen, because it's literally this pressure that literally stops the cells from having enough oxygen and the pressure which causes friction. But hypoxia does play a huge role in pressure injuries, right? And what about chronic hyperglycemia? We already know hyperglycemia plays a huge role in the body's adaptation and diabetes impairs a lot of that, and it impairs the body's normal adaptation to low oxygen levels. Okay, that's why we love vascular. Angiogenesis depends on both oxygen availability as well as intact molecular signaling, and we know diabetes does impair that as well. And restoring perfusion alone may not fully restore healing if the downstream repair pathways remain dysfunctional. Okay, gotta think about things even on a micro level, and that's the whole point. But we love, love, love some vascular. I mean, who doesn't? I love vascular. So, in the end, the future of diabetic foot ulcer care is moving beyond simple covering wounds. Scientists are increasingly aiming to correct the underlying biological defects that are preventing these ulcers from healing. So, while hypoxia, inducible factor stabilizers, gene therapies, RNA based treatments, stem cell approaches, engineered scaffolds, and oxygen releasing biomaterials remain largely investigational for diabetic foot ulcers, they represent a shift towards regenerative medicine. Instead of them asking, how do we address this wound? The next generation of therapies maybe, how do we restore the body's ability to heal this wound? Okay. So, if these approaches continue to prove safe and effective, they might fundamentally change limb salvage by transforming a chronic non-healing ulcer into wounds that are capable of progressing through all the normal stages of repair to finally close. And for decades, people, we treated diabetic foot ulcers by focusing on what we could just see, right? And that's the whole point of research. Every ulcer is more than just a defect in the skin. It's a conversation between oxygen and genes. And when the conversation breaks down, the healing stalls. So the limb salvage future may not depend on just better dressings or better surgery, but learning how to restore the body's function of its own oxygen sensing system. Has been Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.